Let me introduce our three speakers this evening. I'll introduce all of them right now. They are Dr. Eckroth, who is a urologist at Urologic Associates. That is a medical practice located on Northgate Drive. Rika Knoll is an advanced registered nurse practitioner who also works with Dr. Eckroth at Urologic Associates. And Kim Blackwell is a physical therapist with Progressive Rehabilitation Associates. Rika is going to speak first.
So it's so nice to see how many people are here, but it just means that each of you in some way has been affected by overactive bladder. Obviously, you're not alone, and we're here to help you, and there are lots of treatments available, and some of which that you may not be fully aware of. I'm going to start off with just describing or defining what overactive bladder is. We also call it OAB. You may have heard it that way. The clinical term used to describe OAB are frequency, urgency, and or urge incontinence. You don't have to have all of them in order to have overactive bladder. Generally, it is in the absence of infection, and there's an error here on the neurologic conditions. There are some neurologic conditions that can come along with the OAB, and we'll talk about that a little bit later. Normal bladder function is the filling and emptying of a bladder, and it's a complex interplay between the kidneys, nerve signals, and muscles. So as your bladder fills, nerve signals coordinate the relaxation of the pelvic floor, and then the muscles of the urine outlet or the urethra also relax, but then the bladder itself contracts to allow the urine to empty. So anything in that complex that goes wrong can cause these symptoms. Patient symptoms include frequency, and that's voiding more than 7 times during the day. Frequency can be from every few minutes to about every hour or 2. Urgency is the sudden desire to void, which is difficult to defer, possibly losing some urine or dribbling on the way there, or having a gush or complete loss of urine. Nocturia or nighttime frequency is the interruption of sleep more than 1 time at night. And urgency incontinence is the involuntary leakage of urine preceded by a sudden urge. Involuntary contractions of the bladder can be triggered by multiple things. It could be driving into the garage or the driveway, putting a key into the front door, washing your hands. Various things can trigger this sudden urge in running or loss of urine. Some people, especially women, have stress urinary incontinence, but this incontinence is usually associated with coughing, sneezing, bending, lifting, laughing, exercise. Sometimes it's also associated with sexual activity. But stress urinary incontinence is not a part of overactive bladder unless you also have the frequency, the urgency, and the urge incontinence. Usually, there's no physical pain associated with the OAB. If you have pain, it may be something else, but it is presenting as OAB symptoms. But there obviously are significant emotional components. Most patients spend a great amount of time trying to hide the symptoms or manage the symptoms. The costs involved with overactive bladder can involve things as like pads or changing of clothes or lots of laundry. It can even cause somebody to change where they live. It's the #1 cause of nursing home or moving into a nursing home is loss of urine control. It can also decrease the quality of life. Obviously, people try to avoid activities because they don't know where the bathrooms are. It can cause depression and anxiety. and also can affect sexual function. Up to 27% of men and 43% of women have overactive bladder, and the prevalence and severity increases with age. Although the symptoms of overactive bladder are the same in both men and women, because of the different anatomy, they are sometimes treated differently. And this is a slide that shows the female bladder and then the male bladder with the prostate, and the urine tube goes through the prostate. Sometimes men, their symptoms are called lower urinary tract symptoms, or LUTS. Causes of overactive bladder in women can include menopause. So in older women, overactive bladder may be related to skin or blood vessel or muscle changes related to menopause due to the loss of estrogen. There may be vaginal dryness, pain with intercourse, or burning. This is called vaginal atrophy. Bladder, colon, rectal, or the uterus can drop. I'm sure some of you have heard that, or I have a tilted bladder or something like that. That's called a pelvic prolapse. Prior surgeries, cancer, or radiation to the colon, cervix, uterus, or bladder can also cause symptoms. In men, an enlarged prostate is oftentimes the culprit, and the prostate generally starts to enlarge at age 50. It can cause narrowing of that urine tube, and we saw that on the previous slide. You may develop symptoms in addition to what I've already mentioned, such as a decreased stream or hesitancy, which is you think you have to go, you race to get there, and then nothing comes out, and you have to wait for 20 or 30 seconds or longer. Incomplete bladder emptying, or the sensation that you still have something in there, but it just all of a sudden stopped. And then post-void dribbling, which is at the end of the stream, you think you might be done, you go to pull your drawers up, and then you get a little bit more, and it wets the front of your pants. This is a slide that talks about the LUTS that I just described in men. So the green part there, that's the urethra, and all of those factors like the growing of the prostate can push on the urethra there. As I alluded to earlier, there can be conditions that directly impact the bladder. Overactive bladder can be caused by an underlying neurologic condition and often affects those with multiple sclerosis, people that have had strokes, Parkinson's disease, spinal cord injuries, just to name a few. Many patients with neurologic bladder also have mobility issues. You don't necessarily, however, need to have a neurologic disorder in order to have mobility issues. So that's called functional incontinence, but you can still have overactive bladder. Patients with diabetes can also develop neuropathy, and I'm sure some of you have heard that you can lose feeling in your legs or your feet. It can also affect the nerves of the bladder, and then the bladder becomes sleepy, or you can't empty, or it misbehaves, like we've been talking about. And some have cognitive decline or chronic bowel issues. And Dr. Eckroth is going to come up and speak about treatments.
So I'd like to thank Rika for just starting to go over some of the aspects that cause overactive bladder and what it means for patients. And the things that I would like to cover today are some of the treatments that are available for the symptoms that she was discussing. This is kind of an outline that the American Urologic Association has come up with that provides kind of a step-by-step approach to how we should deal with treatment of overactive bladder symptoms. So the first question that should come up is, do these symptoms need to be treated? Now, on one hand, many of the treatments that we use can have potential side effects. The most common ones for our overactive bladder medications, for example, include dry mouth, constipation, dry eyes, and potentially some cognitive or memory issues. I don't know anyone who wants any of those side effects. So you have to consider, on the other hand, are the symptoms worth some of those side effects? So it becomes a quality of life issue. Is the quality of life bothered enough to try some of these if we can manage some of those side effects? An important thing to understand is that for plain overactive bladder symptoms, not the other underlying issues that she discussed, for example, the neurologic causes, but just for overactive bladder, it's not a medical problem that needs to be treated, because if it goes untreated, you won't necessarily have anything bad happen down the road. So our approach to this is based more on quality of life balance. Before starting treatment, it's important to provide education to patients so that they understand that overactive bladder can have a variable course. You may have flare-ups of symptoms, and at other times they seem to improve. Unfortunately, it's also a fairly chronic problem. It does tend to be a long-term issue. It's also important to understand that there's no single ideal treatment for an individual patient or for the population in general. So we do have to sometimes work around with a little bit of trial and error between multiple treatments to find the best one for each patient. One important thing is to find a reasonable goal in your expectations for treatments. It's very rare to have the symptoms completely resolve or go away. So the goal is to come up with an expectation of, right now I'm voiding this many times a day. My goal would be to cut it down to this many, or decrease the number of episodes of incontinence by 50% to start with. Because if you have a realistic goal like that, that's something we can really work towards rather than expecting to go back to the complete normal that you had maybe several years ago, so that you're better accepting of the condition and understand that it may take a while to reach that level of improvement that you want. So again, this is the American Urologic Association outline for the treatment guidelines. And what I would just point out that at each level of this, the idea is to check in and see if you've met your treatment goal. If we haven't met that treatment goal, then we move on to the next step in the chart. And the way that these steps are arranged are that the ones at the top, the first line treatments, second line, those have the lowest potential side effects or complications. So that's the order that these were placed in by my colleagues within the urologic community. And that's the reasoning behind why we start with one area versus another. So first line treatments are chosen because they are completely risk-free. The first line treatments involve behavioral changes. A lot of this is going to be in Kim Blackwell's discussion, so I will leave most of the details to that. So we're going to be going a little bit backwards in our treatment outline here. But some examples of what can be done include bladder training, bladder control strategies, fluid management, which I know most people have figured out on their own a little bit already, and pelvic floor muscle training can actually provide great benefit. Again, these are all risk-free, so even if patients need to go beyond this first line treatment into the second and third line, we don't want them to leave these treatments behind, because even if you get a small percentage of gain in benefit from this, that's less medication, for example, that you need to take to meet your goal. So this first line therapy should be continued throughout. Even if you have to go on to other treatments, you want to continue to do some of these changes that you can do at home all on your own. So the second line treatment are mainly medications. The way that the bladder is controlled is you have central control of what your bladder will do in your brain, and it sends the messages down your spinal cord. There are nerves that exit your spinal cord, and for the ones that control your bladder, they're down in your lower spine here. We call that the sacral area. Those sacral nerves wrap around in the pelvis to reach your bladder, and in that area, the nerves send out chemical messengers to the bladder wall. Those chemical receptors that receive those chemical messages in the muscle are the areas where the medications work. And within the bladder muscle, there are different kinds of receptors. That's why we have different kinds of medications. So for the two classes of medications that we use for overactive bladder, the reasoning behind that is, again, because they work on two different receptors. So the first class of medications are called anti-muscarinics, also commonly called anticholinergics. These are generally what we term as the bladder antispasm medications to make it more understandable. The second class of medication are the beta-3 agonists. Both of these are named based on the receptors that they act on. So with the first class of medications, the anti-muscarinic class, as you can see, we have many to choose from. This is a long list. The ones on the far left side are the common names of the medications. Their brand names are in the center of the list, and you can see that mainly these come in pill form. There are some that are available as a transdermal patch that you put on your skin or a gel that you rub on your skin also. As I mentioned, treatments can sometimes have side effects, so we do have to mention those. So the most common ones for this type of medication include the dry mouth, constipation, blurred vision. Occasionally, these can put patients into urinary retention where they're unable to empty their bladders. Dyspepsia or stomach upset. We keep mentioning impaired cognition. This has been noted on studies with mini mental exams in patients rather than reported by patients. So sometimes people's mental capacities have noted to decline on these medications, particularly in patients over the age of 65. And again, it's not declining enough that the patient or the family notices it, so it's something we really have to be wary of in using these medications in older patients. Dry eyes are pretty common, and urinary tract infections can also occur. There are certain patients who just should not take these medications. That includes patients with narrow angle glaucoma. Then there are also relative contraindications, so patients that they should be used cautiously in. That includes anyone who has difficulty with their stomach emptying very well, anyone who's had a history of not being able to empty their bladder, people who take the long-acting potassium pills, we have to be concerned about that. And I mentioned the frail and elderly again because of the possibility of decreasing their memory or cognitive abilities. And then there are certain medications that you have to be wary about using them together. And unfortunately, you can see they list Parkinson's and Alzheimer's medications. And those patients frequently do have overactive bladder symptoms. So it's very hard sometimes to manage the treatment when the medications can't be combined with their primary problem medications. So of that long list that I put up with the different medications, patients often ask, which one is my favorite one? That really varies from patient to patient. The one thing they have found in side-by-side studies is that they all have pretty similar efficacy in improving patients' symptoms. What they have found is that the pills that are called extended release, or the ones that last all day long with one dose rather than the multiple dosing throughout the day, they tend to have fewer side effects. So that's the one recommendation they make, is to really stick with the longer lasting ones before the shorter acting ones, just to reduce the possibility of side effects or complications from this. Beyond that point, a lot of it unfortunately depends on the cost. And that's going to be different for every patient because all the insurance companies have separate contracts with different pharmaceutical companies. So sometimes it's a matter of trial and error of prescribing one and finding out that the copay is outrageous, so we try another one until we find one that the insurance company accepts. The benefit is that, again, in side-by-side trials, they've been shown to have pretty similar efficacy. So no matter what your insurance company covers, it usually works out pretty well. Now, there is some trial and error, again, with side effects, and this is one area where we will change from one medication to another if needed to try to manage the side effects. And if we document that, the insurance companies also usually accept that and allow you to change. Occasionally, we just alter the dose. We can use a lower dose if we're having problems with side effects. As I mentioned in that list of side effects, I don't know anyone here who really wants to have dry mouth, constipation, and dry eyes all the time. So it's pretty important to make sure that these are actively managed. There are lubricating eye drops. You should use a bowel regimen to prevent constipation. Some of these things should be addressed before we give up entirely on the medications if you're really seeing benefits in your symptoms from them. Now, the second class of medications that I mentioned are the beta-3 agonists. I used plural, but really there's just one medication in this class right now, Myrbetriq. It's a relatively new medication that was recently approved by the FDA. Again, because it acts on a different receptor in the body, therefore it has a slightly different side effect profile compared to the other medications. Some of the side effects they've seen in people who have taken this include high blood pressure, cold symptoms, headaches, and urinary tract infections. And there's a different list of medications that it shouldn't be used with or should be used cautiously with. That includes metoprolol, desipramine, and digoxin. Now, for patients whose symptoms have been completely refractory to both behavioral modification and medications, we might consider moving on to our next line of treatment options. Other patients who have had intolerable side effects, even with active management of those side effects, are also within the group that we consider other treatments on, or patients who simply aren't candidates for the medications because of some of the things I listed, like narrow angle glaucoma, or their age is above 65 and they're having issues with the medications. That's when we talk about our third line treatment options. These include sacral nerve stimulation, also called Interstim, that's the brand name for the company. Peripheral tibial nerve stimulation, much easier to say PTNS for that. And intradetrusor Botox injections, or again, easier just to say Botox into the bladder. So again, we return to the anatomy of what controls the bladder. When they discovered with neuromodulation that stimulating the nerves that affect the bladder help improve overactive bladder symptoms, a lot of people ask the question of how that works. And I'm not sure we have a great answer in the medical community for exactly what the mechanism is. Some people have hypothesized that stimulating the nerves that control the bladder reset the behavior so that they go back to more normal patterns of voiding. Whatever the mechanism of it, they have found that by stimulating the bladder nerves, you get a benefit in your symptoms. They've seen decreases in urge incontinency, frequency, and all of that. Now, the two different nerve modulation ways that we have of dealing with this act on two different nerves, or we approach them in two different locations. So on the close-up here of the sacral spine, again, this is the lower spine near the pelvis, you'll see the top arrow here. That's where we do the sacral nerve stimulation, or Interstim. And you can see here, as those nerves exit the pelvis, you start to see the tibial nerve stimulation that we use for PTNS. I point out the two locations up here in the pelvis because you can still see where they go back to the sacral area, and therefore that's where they act on the bladder. When we get the full picture of the anatomy with a full leg, these arrows point to where we actually administer the nerve stimulation. So again, the top area is for our sacral nerve where the Interstim is placed. That's, again, basically between the buttocks on the lower back. But the peripheral tibial nerve stimulation is down in the ankle. So a little bit different area of access and a little bit different approach to that. So going back to just the Interstim device, this is the actual device that's implanted for patients who undergo Interstim. I know it looks large up on the screen. To give you an idea of its true size, that little metal piece can fit easily into the palm of my hand and close it. So it's relatively small. The Interstim procedure itself takes place in two stages. The first stage is where the wire is placed through the skin in the lower back, near the sacral nerve. That's a test part of the procedure, and we determine if patients are getting benefit from the treatment or not. So with that test procedure, the wire comes out of the skin and hooks up to a temporary stimulator. Patients who notice a benefit in their symptoms then move on to the second stage of the procedure, where the final device, the picture I just showed you, is implanted under the skin at that point. So this is a schematic of the initial placement of the wire. This is the lower spine, so imagine someone laying face down, and this is the buttocks area. The needle is placed right through the skin, and using X-ray guidance, they identify where on the sacral spine. The sacrum is actually a triangular shaped bone, and there are holes in it where the nerves are located. So with X-ray, it's pretty easy to identify the exact location. A wire is passed through that needle, the needle is removed, and the wire is left in place right next to the nerve for stimulating it. So again, with this test procedure, that wire is tunneled under the skin and it comes out of the skin surface. It's attached to a temporary battery pack stimulator, which can be clipped on your belt loop, and you can walk around with it as a test. Occasionally we have that go for 1 or 2 weeks. For patients who know improvement, then the battery pack, the final one, is implanted under the skin, and at that point, everything is under the skin with nothing outside of the body. With Interstim, successful treatment is defined as having a greater than 50% reduction in the number of urge incontinence episodes, where you start to lose urine control before you can reach the bathroom, or a 50% decrease in pad use for incontinence. Now, to look at the results that they've seen in studies of Interstim patients, at 1 month after surgery, 87% reported benefit. This is, again, of the patients who went through with the full procedure for the full implant. And looking at durability of it, 5 years out, they found that 62% were still happy with their results. Again, with every treatment, we have to go through the potential complications or side effects. Some people note pain at the lead site. That means where the wire is. The wire can actually migrate out of location so that it's no longer stimulating the nerve the way it should. Some patients have infection or irritation from the device. Electric shock has been reported. Potentially the need for surgical revision if anything needs to be repaired, or the lead wire needs to be replaced into the correct spot. And also, patients should know ahead of time what some of the day-to-day issues they might run into can be. For example, difficulty in passing through airport metal detectors, and the fact that they will not be able to have MRIs if they have this device in their body. This device is battery powered, so at some point it does need replacement. So it's also important for patients to understand that it will need periodic replacement. The company keeps improving the battery, so every couple of years they announce more years that you can last on one battery, but every couple of years it usually does require replacing the battery pack. So for percutaneous or peripheral tibial nerve stimulation, again, this is just a picture of where we actually access the nerve for this procedure. That's compared to the lower back for the last one, the Interstim. PTNS, we access it in the lower ankle. So as you can see, during the PTNS procedure, patients can either be seated or they can be reclining in a laying position, however they're most comfortable. We use the anatomical landmarks of the ankle, the bone, and the ligament that are easily palpable to identify where the nerve is. The needle is tapped into place. Everyone gets nervous when we talk about needles. This is about the size of an acupuncture needle, so people really tolerate it pretty well. Once the needle is in place, we attach it to the stimulator, which is the machine you see off to the side, and we turn on the test dosing. We're looking for appropriate stimulation of the nerve, so we're looking for the toes to move. Once the treatment is started, the treatment is approximately 30 minutes. During the session, patients typically experience a tingling sensation or pulsation. When someone first starts with PTNS therapy, it should be 1 session per week for 12 weeks. That sounds like a lot, and it is right up front. But most patients can spread that out. Usually we move on to once a month. And sometimes people can spread it out as far as 4 times a year. So looking at the results of this, the early studies have shown good improvement for all overactive bladder symptoms. They've done side-by-side comparisons for patients with non-medications versus PTNS for their symptoms. And they've shown as good or better results with PTNS compared to what used to be our only treatment option of medications. My husband asks about this part of it because he thinks it acts like a sham.
I assured him that they performed the study where everyone got the needles and one person was actually hooked up to the stimulation and the other people were not. And only the people who received the stimulation really saw a benefit. I'm not sure he still believes it. He's an orthopedic, so he tends to be a disbeliever about these things. The results that people see do seem to be durable as long as they continue the treatments. The real upside to this for me as a person looking for other treatments for my patients is that the side effects or complications are very rare to see and very minor. Perhaps some bruising at the site where the needle goes in for people who are on blood thinners, but even that is pretty rare to see. A key point to the neurostimulation treatments that I reviewed is that the benefits only last as long as treatments are continued. So it's important to understand that when telling patients about these, that they need to be continued. For the Interstim, you continue to have the implant in your body and it provides stimulation most of the time. Some people turn it off at night. And for the PTNS, you need to have routine intermittent treatments, whether that is for you every month as maintenance or whether it's every 3 or 4 months for maintenance. Now the last one is the intradetrusor or in the bladder Botox that was just recently FDA approved. This is a picture of how we use a cystoscope to actually place it into the bladder. We can use rigid cystoscopes, or as you see here, it's a flexible cystoscope, which is actually smaller than a urinary catheter that goes in the bladder. Multiple small injections are made throughout the bladder. Depending on a patient's comfort level, this can be done under anesthesia or in the office with just anesthesia into the bladder. The way that Botox works is those nerves I talked about that stimulate the bladder, they release the chemicals to affect the bladder muscle. Botox inhibits those chemicals from ever being released. So that's how the mechanism works. So basically, you're blocking the muscles from being activated. We all know how Botox works in other places. It inhibits muscle use, and the same is in the bladder. So far, again, it's only been recently FDA approved, but the studies that they used before approval did show good improvement in overactive bladder symptoms, particularly in patients with pretty severe urgent incontinence. Again, we have to talk about potential complications for any procedure. The most common one has been increased urine residual. That's the nice way of saying that people can't empty their bladders well afterwards. So you have to reach a fine balance between inhibiting the muscle enough to improve the symptoms, but not paralyzing the bladder entirely. So there's been a rate of about 6 to 10% of patients who have difficulty emptying their bladder after the procedure. The other 90 to 95% did fairly well without any issues. But for those, 6 to 10%, that means that they do need to place a catheter in their bladder intermittently to empty until the Botox wears off. That's why that is a very important factor to discuss with patients up front before the procedure. The other side effects that we're seeing less commonly include a urine infection, blood in the urine, dry mouth, difficulty swallowing, impaired vision, eyelid weakness, arm weakness, torso weakness. Those are similar side effects that can happen when Botox is injected anywhere in the body, and the reports are very rare of those ones. Again, number one thing to understand before considering Botox is the potential need to have a catheter placed to drain your bladder if you're unable to empty. Also, the important thing to understand is that is not permanent. The side effects do wear off. The downside to that is that the benefits of Botox also wear off. Botox used anywhere in the body does need to be injected repeatedly to get the continued benefits. The average length of time they've seen between patients needing re-injection for overactive bladder symptoms is about 6 months to have repeat treatments. Occasionally, early in the treatment course, it's more frequent than that. Now, this is a little bit outside the scope of our discussion tonight, but there are cases of completely unmanageable overactive bladder symptoms. frequently associated with anatomic or neurologic issues. For those, we will occasionally do surgeries that are a little more extensive. We divert the urine away from the bladder, or we actually make the bladder larger by using a piece of bowel to enlarge the size and holding capacity of the bladder. Not really within the scope of the discussion today, but I wanted to be complete and mention that we do sometimes do that for severe refractory cases. Now, the take-home points that I would like you to remember from our discussion today. Basically, the overactive bladder symptoms include urgency, frequency, and urge incontinence, or losing urine before you reach the restroom in time. The fact that these are very common symptoms, particularly as we age, they continue to become more bothersome. No treatment is needed, but if your quality of life is suffering significantly due to symptoms, I want people to know that we do have a multitude of options. There's no single treatment that is best, otherwise this would be a very short discussion. And management of the symptoms involves identifying a realistic goal for what you would like your symptoms to be, and then using a trial and error of the different treatments we have available to try to work toward that goal. Again, you have to balance the potential side effects and complications with the benefits of it and find a happy medium in there somewhere. I'm going to turn it over to Kim Blackwell to go over some of the behavioral changes I talked about.
So I'm going to take a step back here, and we're going to go back to the first line treatments, which include physical therapy, behavioral approach, and pelvic floor therapy. So just this is kind of a review of what Rika was describing, but overactive bladder consists of frequency, urgency, and or urge incontinence episodes. So once again, frequency is going to the bathroom anywhere from several minutes up to 1 to 2 hours. Urgency is that strong desire to void, often with a difficulty or complete inability to be able to control that urge. And it can also be associated with urge incontinence, where you're actually having some leakage with that urgency on your way to the bathroom. Physical therapy for overactive bladder, I separated into 2 general categories, behavioral approaches, and we'll talk more about each one of these at the upcoming slides, but that consists of education regarding bladder irritants and things in your diet that can contribute to the irritability of it. Filling out a bladder log, or what a bladder diary. Basically, it's just keeping track of when you go to the bathroom, how much you're going to the bathroom, what you're drinking, when you're having urge incontinence if you are. And then from that, we will try to start a bladder retraining program, which is basically trying to get your bladder on a more predictable schedule and build your confidence in being able to control those that urgency. We also, another component that I often will do is pelvic floor strengthening. And overactive bladder is not necessarily thought to be caused by weakness of the pelvic floor. That is more the stress incontinence that Dr. Eckroth talked about with, or Rika, with coughing, sneezing, lifting, things like that. However, in the people that I treat for overactive bladder, I do find that there often is a component of weakness to the pelvic floor. And so we have various ways of treating that with strengthening. I do also want to mention that my presentation, I focused more on people that are having overactive bladder without pain. If there's any pelvic pain associated with it, any muscle spasm of the pelvic floor, pelvic floor strengthening would not be part of the treatment, and it would go in a different direction with that. So for our purposes tonight, we're talking about overactive bladder without pelvic pain. I'm not going to spend a lot of time talking about studies, but I did want to include this one. This is a randomized controlled trial, which is kind of the gold standard of research studies. This was performed in 2002. They took 152 women, ages 55 and up, that had urge incontinence episodes more than once a week. And they randomly assigned them into 2 groups. One group did the bladder logs only. So they were just keeping track of when they were going to the bathroom, but they didn't get any actual modifications to that. And then the treatment group was seen once a week for 6 weeks, and they did do the bladder logs, but they also had the behavioral modifications of bladder retraining, education regarding the bladder irritants, and treatments in line with that. What they found was that the behavioral techniques had good success. Overall, they had a 40% reduction in incontinence episodes, and that was maintained for 6 months. 30% felt like they were pretty much 100% improved with the incontinence. Not to say that they weren't, maybe still had a little frequency, but with the incontinence, they felt completely dry, and about 40% felt about 3/4 improved. So what they found from that is that behavioral techniques, physical therapy is definitely a great place to start with first-line treatments. So now talking about what I do in physical therapy, we're going to start with the behavioral modifications. There's a sheet at the back that talk about bladder irritants. Basically, these are foods, beverages in our diet that are thought to contribute to urgency, to frequency, to the irritability of the bladder. Often these are alcohol, caffeine, anything with acidic properties like citrus fruits, tomato-based foods, spicy foods, things like that. As well, in physical therapy, we talk about fluid management and fiber intake. Constipation can make this problem worse, so always make sure that you're getting lots of fiber and that you're not getting constipated. At a patient's first visit in physical therapy, they will receive a bladder log to complete before their second visit, and it's just a small booklet. They can put it in your purse and take it with you. Basically what that does is it keeps track of all your habits. So it keeps track of what you drink, how much you drink, when you're going to the bathroom, how much you're voiding, as well as if you are having any urge incontinence episodes, when you're having those, and how much is it? Was it just a few dribbles? Was it complete wet outerwear and everything? And then when you bring that back on the second visit, we take a look at that. I take a look at that with the patient, and we try to find patterns. Is the urgency often in the morning after you've had coffee, or after you maybe take a diuretic, or things like that, and try to find patterns in things that we can modify. And from that, we will start a bladder retraining program, which is scheduling bathroom breaks. So if I have someone come in and they show from their bladder log they're going to the bathroom consistently every 45 minutes, we'll start there and we'll say, okay, start with maybe an hour, and teach them delay techniques to try to make it to an hour and get the bladder used to that, and then gradually try to increase from there. So when we talk about the delay techniques, when you feel that urge to go to the bathroom, when you feel that strong urgency, the automatic response is to jump up from your chair, run to the bathroom as fast as you can. And that's often when people will get some urge incontinence because they're hurrying, they're out of control, their muscles are not engaged, and that's what can lead to some of that incontinence episodes. So this is what I tell people when they to be able to delay the urge to go. Is the first thing you need to do is stop, take some deep breaths, do a few quick Kegel exercises, which I'm sure many of you have heard about. We're going to talk a little bit more about that. But basically, those are just quick pelvic floor contractions of the muscles at the bottom of the pelvis. And that actually sends a message to inhibit the bladder. It's called reflex inhibition. And by tightening those muscles, it helps send a signal to the bladder to settle down a little bit. And it helps ease that urgency a little bit. You can put pressure to the perineum, so sit down, cross your legs if you need to. Deep breathing and positive self-thoughts, saying, I can control my bladder. I can do this. It's, I can wait a few minutes until I get things under control. Distract yourself, count backwards. imagery. I've had people imagine the bladder as a balloon, and if it's only been a half hour since you've gone to the bathroom, you know that the bladder should not be completely full. You can imagine the bladder as, being just as that balloon, only being half full. And then when you get the urge under control, you can walk slowly and controlled to the bathroom. So we're going to move into the second part of the treatment, and that is pelvic floor training. And I apologize, this picture ended up a little bit blurry when I went to enlarge it for the PowerPoint. But you can see, basically, I'll point out where the pelvic floor muscles are at that we're working when we talk about those Kegel exercises. They are the ones that sit right at the bottom of the pelvis. They create a sling at the bottom of the pelvis. They have three general functions. First, they sit at the bottom there to support the pelvic organs, the bladder, the uterus, prostate, the abdominal organs. They have a function in sexual appreciation, and they also help stop and start the flow of urine. So when you are going about your daily activities, those muscles are, I don't say contracted, but they're engaged enough that they help shut off the sphincters of the urethra to keep us dry. And when we want to go to the bathroom, those muscles relax and let the urine pass through. To be able to identify those muscles, a lot of people come in and they know they're supposed to be doing those Kegels, but they have no idea what it is. They're not sure that they're doing them correctly. And so that's a lot of what we work with in PT when we're doing the pelvic floor, is being able to identify those muscles. So when we talk about pelvic floor strengthening and those pesky Kegel exercises, within our body, we have different types of muscle fibers. We have muscle fibers that are designed more for endurance and long hold, and we also have muscle fibers that are more powerful, and they work more for quick contractions. Within the pelvic floor, you have both of those muscle fibers, and so we do work both types of contractions, being able to hold them longer as well as doing quick contractions. We also do a lot of various positioning. So there's a lot more to the Kegel exercises than maybe what you ever knew. Generally, what we start with is having a person lie on their back, and that takes gravity out of the equation, because when we're standing, to be able to do a pelvic floor contraction, if you think of that picture, you have to contract those muscles up against gravity, holding up the abdominal cavity, the pelvic organs. So by lying on our back, we take gravity out of that. And as someone gets stronger, we eventually get into sitting and standing. And then we also do functional strengthening, or what we call the knack. And that basically is just teaching someone to engage their pelvic floor with daily activities. So lifting a laundry basket or climbing stairs. I work a lot with overactive bladder, especially with going from sitting to standing, because that's a big problem. When people feel that urge to go, the first thing they need to do is they need to stand up and they need to walk to the bathroom. So being able to engage the pelvic floor during those activities is very helpful for people to be able to control that urge incontinence. If someone is having some difficulty being able to identify those muscles with the cues that I'm giving them, we do have biofeedback in our clinic, or what's called EMG. Basically what that is it's a machine that uses electrodes that is placed on the pelvic floor, and it measures your muscle activity. And what it does is it turns it into a graph form that will show up on my laptop in the room, and it allows the patient to be able to see what those muscles are doing, and it helps increase their awareness of what contraction we're looking for. So here's a picture of someone that is doing pelvic floor EMG. It's, when people hear EMG, they think that it's going to be painful. It's not painful. The electrodes are not doing anything except measuring what you're already doing. We can do it a few different ways. So it's flexible. We can do either external electrodes that get placed on the pelvic floor, or I do have internal electrodes in the clinic as well, which are a little more sensitive to isolating the pelvic floor. Here's what the graphs would look like from the biofeedback, and you can see on this bottom right corner here, you can see where that line goes up. That's when those muscles are contracting, and then they're holding it for a period of time, and then they relax and the line goes back down. If you compare the bottom left to the bottom right, those are those quick contractions on the left versus the longer hold contractions on the right. So that's what you would be looking at when your muscles are contracting and relaxing. So as far as physical therapy, a lot of people come into my clinic and they're not entirely sure what we do in physical therapy. They're not entirely sure what to expect at the first visit. You can bring in your PT referral if you have a referral from the doctor. Over at Urologic Associates, they do a great job of just faxing it, so often it's already there, along with any medical notes, which is helpful for me. We generally ask that the patient has had a pelvic exam within the past year, and that's just to rule out anything outlying that could be going on, contributing, that would be more medical in nature and outside of the scope of physical therapy. That first visit will usually take about an hour. Follow-up visits are usually about 30 to 45 minutes. Generally, I see people for overactive bladder maybe once a week, every 10 days or so. If we're doing the biofeedback for a lot of strengthening, it might be more frequently. And generally, I'll see people for anywhere from 4 to 8 weeks, so 4 to 8 visits generally. The first visit, I do a musculoskeletal screen, including the lumbar spine, the low back, as well as the hips. And that, once again, is just to check the lumbar spine. A lot of people that have this condition have some associated low back issues like stenosis or things. So just check to make sure that there's nothing that could be contributing from the lumbar spine. We also check the pelvic floor, of course. That may include a manual internal assessment of the pelvic floor strength. That just allows me to be able to know if the person is able to do a pelvic floor contraction and a Kegel correctly and be able to isolate those muscles. From that first visit, you'll be started on everything that we just talked about. From the home exercises, we'll tailor those to exactly where you're at with strength, as well as a lot of the educational stuff and the behavioral techniques, and you'll get that bladder log at your first visit. The biofeedback, once again, may be included if you're having difficulty being able to isolate those muscles. Goals in physical therapy and what we're looking for outcomes, reduce the frequency and the severity of the leakage. So trying to be able to, once again, like Dr. Eckroth said, those realistic expectations may be going from having to wear a large pad to, a panty liner, or decrease the frequency of the leakage by 50%. Be able to increase how long you're going between bathroom breaks. So if you came into me at 45 minutes, maybe we'll set it for an hour and a half or 2 hours and just go from there. Improve your ability to control the urge and be able to have some of those tools that you can talk yourself through when you do feel that urgency to say, okay, I can do this. I can wait for a moment, finish what I'm doing. I can make it to the bathroom. And improve your confidence with that. And we've talked a lot about quality of life with this. And, one thing, when patients come in to see me, it doesn't matter if it's for overactive bladder or orthopedic conditions, everyone has things that are important to them that they want to get back to doing, whether it's their kids or their grandkids, or if it's a bowling league or social activities. And I think that's our goal as a medical team, is to get you back to what's important to you, whatever that may be. So thank you.
So a question as to whether the first and third line treatments could help with nocturia, which would be yes. People do note an improvement in nocturia. We focused mainly on daytime symptoms today, but definitely with nighttime frequency as well. As far as insurance covering the third line, PTNS, I have not had to prove that anyone is on the medications or that they have failed it.
This is a recent thing that we're offering mainly because Medicare has finally approved it in the state of Iowa. There were 10 states where they did not approve it. We were one of the last ones. So now Medicare is covering it. Insurance companies are following closely behind.
Okay, but if one is with a private insurance company, because they did check for me about a month ago.
Mm-hmm. That may change with time. Again, the Medicare coverage was a relatively recent change. So I'm hoping that the insurance companies follow suit. Yeah.
PTNS, generally the first thing that improves is nocturia, or the nighttime frequency. So just since we're, yep, so generally people will notice a difference in, or improvement in their nocturia between weeks 4 and 6. Sometimes it may take up to 12, but in the amount of people that we have right now, that's the first thing that we've noticed, and in the literature it says that as well. Mm-hmm.
For generally nighttime complaints where daytime is not as bothersome for you, there are also things like DDAVP medications, which, I know, decrease your body sensitivity, decreases the amount of urine you're producing overnight. Used pretty rarely in adults, but for patients who have only nighttime problems, it's pretty useful.
The question was what to think about the just in case going to the bathroom. Is that your question? Or preemptively going to the bathroom if you're going to go on an airplane or if you're going to go on a bus ride. What I generally talk with patients about, and it talks a little bit about it on the bladder health sheet as well, is to avoid the just in case moments. And I tell patients within reason. If you are going to be on a 3-hour airplane ride, by all means, use the bathroom. If you're going to go on a long car trip, use the bathroom. What I do tell them is to practice if you're going to go grocery shopping, and that's a time where you would normally go to the bathroom, but you're only going to be gone for a half hour, try to avoid if you can. So I tell them to try to avoid it within reason.
The question was, is there an overactive bladder medication that you can get over the counter? Yes. Recently, in the last, I think even couple of weeks or months, Oxytrol, it's a patch. It is an oxybutylene medication, so it was on the list. It can have the same side effects of dry mouth constipation, less likely when it's through the skin, and it's also a lower dose than we would prescribe in the office.
So the sling operation is still definitely used. The purpose of the sling operation is for stress incontinence, the coughing, sneezing, bending, lifting, exercising, causing leakage. So it's for a different purpose. And one of the reasons that when people come in to discuss stress incontinence, we go over the questions about overactive bladder is sometimes after a sling, people do notice an increase in their urgency and frequency. So they sometimes go hand in hand, sometimes one follows the other, so we frequently manage both together. But it's not necessarily for overactive bladder symptoms. Mainly because of the potential side effects. I know I focused a lot on the side effects with medications, but complications from procedures can be bothersome. So that guideline with the step-by-step is from the American Urologic Association. As a community, that's the recommended stepwise progression that we use. It doesn't mean that everyone has to follow the same steps necessarily. It's not an absolute necessary.
If there aren't any more questions, I would just like to thank our 3 speakers this evening. This was a wonderful presentation. I sure learned a lot, so thank you very much.
You're watching City Channel 4. On TV, online, on demand, on Facebook, and now on the go on your mobile device.